Macular degeneration is a disorder that affects the central area of the retina, which is important for seeing fine details. The most common form occurs in people older than 60 years old, and that's why it's usually known as age-related. It causes a central loss of vision called scotoma, as replicated in these photos. It starts out as dry macular degeneration, which is slowly but gradually progressive. On optoexam, you'll see drusen spots, which are basically fat deposits. As the disease progresses, the central scotoma gets bigger, but peripheral vision is usually preserved. Then, in about 10% of people, dry MD progresses to wet MD, which is rapidly progressive. It's caused by neovascularization under the macula. Blood and fluid leak and further damage the macula. This causes acute vision loss. The earliest sign is that straight lines begin appearing distorted and wavy. Take a look at this example. People who have dry MD screen themselves with the Amsler grid. When the lines become wavy, they know it's time to call the ophthalmologist. Treatment is with VEGF inhibitors to prevent further neovascularization. Visual field defects. There are 3 rules you need to remember, and then you can reason your way through most all these lesions. The fibers from the nasal retina will cross at the optic chiasm. This translates into the temporal part of the visual field. Hemianopias must occur before the lateral geniculate nucleus. Right. After the LGN, individual lesions produce quadrantic anopias. Now, thirdly, the superior radiation carries info from the lower visual field. The inferior radiation carries info from the superior visual field. Now, what would a lesion in the optic nerve produce? The optic nerve is before the optic chiasm, so this lesion would produce a complete anopia on the affected side. What would a lesion in the optic tract produce? Here you would get a homonymous hemianopia. There is a visual field defect on the temporal side of the contralateral eye and the nasal side of the ipsilateral eye. What about a lesion in Meyer's loop? What would this cause? Well, this question requires some two-step thinking. First, is the temporal or nasal side affected? And second, is it the superior or inferior field of vision? If you have a lesion in the right Meyer's loop, then you have impairment of the nasal field of vision of the right eye, the temporal side of the left eye, and it's the superior fields. The medial longitudinal fasciculus is a myelinated tract that allows for horizontal conjugate eye movements. The tract bridges communication between the abducens nucleus and the contralateral oculomotor nucleus. Thus, when the eye looks left or right, one eye abducts and the other adducts from smooth action of the lateral rectus and the medial rectus. However, when the MLF is injured, there is a medial rectus palsy when attempting to look laterally. The eye can't tolerate seeing double, so nystagmus will form in the eye that is looking outwards. Bilateral MLF is pathognomonic for multiple sclerosis, especially when seen in young female patients. The MLF runs down the medial pons, thus a stroke in that area in older patients can also cause internuclear ophthalmoplegia.